Yeah. So it does get better, but the thing is that you just have to memorize all this. And I just wanted to say that pre-reading lecture GLS synth, Google searching images, looking at complete anatomy, working in on Saturday and Sunday, working in groups, asking questions to lecturers, are all very important things that just has to be done for the anatomical weeks. At the same time, though, like on the plus side, I do believe week 2 of GH, EH, and MSS were designed to be a little easier just to accommodate this week. So just try to do it as much as you can. There's nothing to explain here. You just need to memorize it. That the more times you go over it, the easier it becomes. And essentially, this is just all the nerves and plexuses. And again, if you are a little behind on week 1 because you haven't really got the ideas down, that's fine. First, start off with your bones and then muscles and then innervation. Learning the innervations to muscles where you don't even know where they're located is not going to help. It's just going to further confuse you. So, in terms of female versus male anatomy, we do have some general differences. So, the male anatomy is going to be external to the pelvis, superficial perineal pouch, versus the female anatomy is going to be internal to the true pelvis slash pelvic cavity for the most part, right? Now, here we're looking at the female anatomy. I just wanted to quickly highlight some quick things. Notice how the bulbospongius muscle is not fused here versus in the males it is. You can notice the ischiocavernosus muscle. We have the superficial tremors perineal muscle. You have this perineal layer right here. And then you have the suspensory ligament of the clitoris right here. Now, in terms of ovary development, something that is really good is when you're able to compare and contrast two different things. It shows depth and it shows that you can actually explain a concept. So similar to the testes, it develops high on the posterior abdominal wall in utero and it descends before birth. We're talking about the ovaries, by the way. Unlike the testes, the ovaries do not migrate through the inguinal canal into the perineum. They stop short and assume a position on the lateral wall of the pelvic cavity. Now, here's some quick things that you should bare minimum know. So we have the vagina right here, cervix. You have the body, the fundus, which is essentially the top. This is actually where this is considered to be the best spot for implantation due to its high vascular tone. You also have the opening to the uterine tubes, and you have the uterine tube itself. Notice here that this structure kind of cups over the ovaries. It doesn't actually touch the ovaries, which is why it's actually the most common site of ectopic pregnancy. Now, in terms of I want to make sure I get it right. The axis of the vagina, we're going to talk about these two different angles that are formed. So this angle right here is the angle of antiversion, and this is the angle of anti-reflection. The reason why this is important is because you can notice how the uterus is essentially leaning over the bladder. And if it leans over to the bladder to the point where it's considered anti-flexed, or it's basically very tipped forward, this ends up creating certain pathologies, hence its importance, right? And then you also have your anteverted uterus. So anteverted is where the inferior or cervical part of the uterus is anteverted if inclined anteriorly, and this is a more common position of the uterus, although some women have retroverted uterus tipped posteriorly. I guess a symptom of antiflexed uterus could be maybe there's more pressure on the bladder, so this could lead to incontinence to some extent. I'm sure there's different pathologies. We just don't really get into them now, but you do need to know these two differences right here. Now, in terms of ligaments, there's something called the broad ligament, and it's not actually a ligament. What the broad ligament is doing is it's connecting the uterus to the ovaries, to the uterine tubes, to the ovarian fimbriae, to the ovarian vessels. It's just connecting to everything, and it's carrying blood vessels and providing a certain type of blood supply. Now there's two other ligaments I wanted to highlight. One is the suspensory ligament right here, and you also have the ovarian ligament. So the suspensory ligament it's kind of just how the name implies. It's suspending the essentially the ovarian vessels, lymphatics, and nerves, and is contributing to a lateral part of mesovarium of the broad ligament. What does that mean? It's just contributing to part of the broad ligament's structure. Let's just say that. The ovarian ligament also has an attachment to the ovary and uterus, and essentially it's just a remnant of the gubernaculum, which you'll go over in lecture. That is the most summary or intro to week 2. Again, the lecture is imperative. It's imperative that you go in person and do the GLSs all the time, but especially for this week.